and they are on time. So we're going to talk to you today. There is a lot to talk about as it relates to 340B. Oh, I'm sorry. Also, you could post questions. No one else sees your questions. We will answer all questions that are posted. It won't necessarily be on the webinar today. We might get to some of them today. If not, we'll answer them at a later time. Okay, so for 340B, there are many issues that FQHCs face with regard to 340B. When Barbara and I were talking about what we should present, we decided that if we did a webinar on everything relating to 340B, it would have to be about a 9-hour webinar. So we decided that for today, for this presentation, we would talk about contract pharmacy issues specifically, and we will have additional webinars at a later date to talk about other issues relating to in-house pharmacies or other things relating to 340B. But for today, we want to focus on, many of you have contract pharmacy arrangements, and Barbara is going to walk you through, many of the requirements that go with it. And we also want to touch on, we've been getting lots of calls over the past relatively short period from FQHCs that have relationships with contract pharmacies and call us to say, yes, we have this great relationship in place, but it turns out the pharmacy is not actually giving us the money. What do we do? So part of what we're going to talk to you today about is being strategic about it, not just signing up with as many pharmacies as possible, but signing up with pharmacies who make sense for your population and who you feel like will actually comply with their contractual requirements. So with that, I'm going to turn it over to Barbara.
Hi, this is Barbara Noth from Garfunkel Wild, and today we're going to talk about 340B in the context of the contract pharmacy. First, a quick program overview for 340B. Obviously, everybody knows that it's a federal drug discount program that provides front-end discounts on outpatient drugs. What is an FQHC? We're going to use that term throughout here. Obviously, all these health centers, which could include FQHCs, FQHC lookalikes, community health centers, migrant health centers, and all of the other types of health centers that are qualify for 340B. And we're going to use the term FQHC throughout this presentation to include all of those possible programs. Remember that the intent of the program is to allow the covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So what you are finding is that there is a movement now for all covered entities to be transparent about how much they are making on the 340B program and to state how they are using those monies. For example, that you are using it to expand services provided to your patients and provide services to more patients. And that's obviously what all of our FQHCs are doing, and a lot of you will already have to account for the amount of 340B revenue for HRSA purposes anyway, and I know that Ryan White programs are, the 340B income is considered program income and has to be used for the purposes and conditions of the grant itself. Finally, with respect to FQHCs in general, that in your notice of grant award, you are required to secure the best prices available for your outpatient prescription drugs and maximize the results for the health center and its patients. So there's been some discussion as to whether or not if you don't participate in 340B that you're actually complying with that mandate. But, in our view, you're only required to participate in 340B if you want to. And but for most of our clients, the 340B program is critical to their operations. When it comes to 340B and compliance with respect to the entire program of 340B, you've got several pockets of required compliance. You've got eligibility requirements, registration requirements, requirements related to diversion of drugs, and then duplicate discounts. Unfortunately, all of those categories apply when you add in your contract pharmacy. So all of these specific areas of compliance are included in your contract pharmacy compliance program. And it's interesting to note that right now there is OIG scrutiny, as well as pharmacy, big pharma, and even managed care plans are bringing on a backlash to the contract pharmacy arrangements, excuse me, because of the proliferation of contract pharmacies and as well as third-party administrators. In 1996, when this was first introduced, HRSA said that it would defeat the purpose of the program not to permit contract pharmacies, but they only permitted one per covered entity. And in 2010, that's when they permitted unlimited contract pharmacies, which resulted in this proliferation and ultimately this backlash. It's interesting for those of you who are involved in the 340B program for quite some time, which I have. You can remember that originally the goal of the Office of Pharmacy Affairs was increased use of the 340B program, and that's what now it's going the other way. So we're looking now at slide number 5, talking about eligibility and registration. As you know, new contract pharmacies can only register on the HRSA'S 340B database during 4 two-week windows a year, and it's important that you understand that there's an extended registration period for FQHCs only. HRSA has recently been extending these deadlines for new FQHC sites until the 9th day of the 3rd month of each quarter. But while the extended registration period does not apply to new contract pharmacies, when you are registering a new site, at that time you can register all contract pharmacies that new site will work with. So you do have some extra leniency there when it comes to registration.
So just to clarify, Barbara, that means if I have an FQHC and I have 5 sites and all 5 sites contract with a specific pharmacy, I have to register each of those sites with that pharmacy separately?
Not if they're all under the same parent. But if you are registering a new site, then you may want to register all the contract pharmacies that it will work with at the same time.
Okay.
So each eligible location that plans to use or prescribe 340B drugs must be separately registered on the Office of Pharmacy Affairs website. So even if you have a location that does not have any floor stock and doesn't dispense any medications, if it's going to be prescribing 340B drugs, that entity location has to be separately registered. Now, when it comes to registering new contract pharmacies, one of the things that we think that you should be doing is doing some due diligence on each contract pharmacy. And one of the things you should look at is the contract pharmacy's compliance record. We can look at the state database for disciplinary actions. There's been a few times when I've looked at that for my clients and have found some very interesting activities which were brought the integrity of the pharmacy into question. Then you are going to be evaluating whether or not the location is convenient for your patients, if it's a specialty pharmacy, if they offer a mail order, and also what medications are available. So do they handle the medications that you need for your patients? You would also look, especially with community pharmacies, whether or not they have the experience with 340B, especially if you are not particularly experienced with contract pharmacies. Having a contract pharmacy that is also not experienced in 340B can be quite a headache, especially with respect to Medicaid managed care compliance, if you are going to have Medicaid managed care run through your pharmacy. And most of you would like to do that, I'm sure, because a lot of our patient population is Medicaid managed care these days.
Right. So just to add to that, you also probably want to make sure, and this applies to everything in an FQHC, you want to make sure you're using an attorney who understands FQHCs for the simple reason that they may be able to provide you some guidance about it. So we had, about 6 months ago, one of our FQHC clients called us to say they wanted us to review a contract with a specific contract pharmacy at the same time as we were actively in litigation on behalf of another one of our FQHC clients with that pharmacy, because that pharmacy had not been paying them the money for it. And so if they had just reached out to the, the local whoever attorney, the user just signs, which we often find that FQHC just sign the contract pharmacy form, say what difference does it make, they would have now been getting into bed with an FQHC with a pharmacy that had, I'll use the word stolen money from a fellow FQHC. Mm-hmm. You also might want to talk to your the FQHC association in your state, because they may have heard some not so great things or maybe some positive things about the contract pharmacy that you're thinking about, right? If you're talking about a national player, the Walgreens of the world, CVS's, you have less of a concern for that. But if you're talking about, Joe's Pharmacy, then you have much more of a concern. Exactly.
The other aspect you need to consider is whether or not the pharmacy has any third-party administrator vendor restrictions. So we'll call those people TPAs, which is just generally the phrase that's used to describe the type of vendor that provides third-party administrative services for covered entities with respect to all of their contract pharmacy arrangements. Now, some of your larger chains only restrict themselves to certain TPAs that they will work with. For example, Rite Aid uses Capture RX. Walgreens won't use any third-party administrator. CVS requires you to use WellPartner. Mind you, CVS and WellPartner are related entities, which I think it definitely raises some antitrust issues, and I'm really waiting for somebody to challenge these tie-in arrangements between the contract pharmacies and the PBMs and the TPAs that they require you to use. So we're turning now to slide 6 and talking about the OPACE, which has recently been updated. It's been a few years now. Most of you probably are comfortable with it now. So the requirements with respect to contract pharmacies that need to be remembered, excuse me, are that only the authorizing official may register a new contract pharmacy. In the old days, contract pharmacies could register themselves, and then the authorizing official would receive an email request for confirmation. This is no longer permitted, and we have to have the AO has to actually register the contract pharmacy personally. It's important also that you do not register a contract pharmacy until you have a written contract in place. There was a very common practice, because you are not able to get a contract pharmacy registered except during the window periods. A lot of my clients were going ahead and registering them and then sending the contracts over to us to get reviewed and signed. In one situation, I had a client who registered 10 new contract pharmacies without contracts in place. Then they got their audit notice, and we had to scramble to get contracts in place before having to respond to HRSA'S request for copies of all of these contracts. And we ended up actually terminating some of them because we just couldn't get them negotiated in time. Mind you, this was a big scramble when we should have been concentrating on audit preparation. So also, HRSA has been lately, they've been asking for copies of the contracts, which they are permitted to do between the time when you register them and when the start date is in the next quarter. So you better be ready to provide those in case these are requested. And also, your authorizing official has to affirm all of your obligations on recertification. And during that recertification process, he or she has to certify that the covered entity will be in compliance with all of the 340B program requirements, including contract pharmacy arrangements. And it's interesting that on that recertification form, that's where they require us to agree to perform self-disclosure for any breach of the 340B program requirements. This self-disclosure is not required by the statute. It's only been added to the recertification, which is how HRSA has done an end run around the regulatory process. So looking at all of our different compliance subjects with respect to contract pharmacy, first one we'll look at is diversion. which you know that the auditors are going to focus on the patient definition, the prescriber eligibility, and also the location from whence the prescription arose. Is that site properly registered? Was the service that was provided in scope? So any use for any other individual constitute diversion. And you have to have a lot of documentation with respect to any referrals. If you're trying to capture referral prescriptions, the adequacy of your documentation is key. And we also have to have proper inventory control. So most contract pharmacies are operating on the virtual or inventory or replenishment system. We'll get more into that later. But what do you have to watch out for in the FQHC setting? You have to watch out for physicians who have outside practices. That's a very important aspect of your eligible prescriber monitoring and compliance. You need to be able to distinguish scripts written at the FQHC or any of the registered sites from scripts that are written outside, if you have a physician who has an outside practice. Your 340B third-party administrator should be able to help with this. But when you are establishing parameters for eligibility, you should start with the written location as a threshold eligibility criteria, meaning that when they're looking at each claim to determine whether it's going to be eligible, the first thing that your third-party administrator should be looking at is where that prescription was written. The service site where the drug was ordered or dispensed is going to be, hopefully, there's a way to mark it on your e-prescribe or to otherwise make sure that they can distinguish that. Generally speaking, you would provide a list of your written locations that would qualify, and they would be coded into the system by your third-party administrator. One of the things that's important is that the script that's written or drugs that are administered or dispensed have to be in clinical sites that are listed on the OPACE system as registered, or they have to be provided in conjunction with other services that are listed in scope on your Form 5C of your scope of project. And each clinical site must be approved under the scope of project and listed as active in the electronic handbook in order for it to be registered in the OPACE. Examples of other services that are in scope and may result in eligible prescription include home visits, clinical outreach events, and sometimes hospital services that result in prescriptions for outpatient use.
Right. So this is, I think, one that could be very problematic, especially if you have specialists who are, where, you have a cardiologist who comes to your site, one day a month, and now is writing prescriptions and going to the pharmacy. What process do you have in place to be able to track that the pharmacy is only filling 340B for the prescriptions written at your site as opposed to the ones that the physician writes from his private practice? And if you're doing electronic scripts, then sometimes that's easier because it's coming from your EMR directly, and so theoretically they should be able to track it. But at the end of the day, it becomes your responsibility, not the pharmacy's responsibility. And often the person in the pharmacy will just see Dr. Smith and not really think about, did it come through the FQHC's EMR, did it come through their personal EMR?
Mm-hmm. So once again, the biggest diversion issue is the prescriber list and that being out of date or inaccurate. The list we recommend should be updated at least monthly or more frequently for larger organizations that have significant turnover. And you should be providing that list to your contract pharmacy or to your TPA as needed, depending on which one is making that comparison on a claim-by-claim basis. And as we said before, you watch out for your prescribers who work elsewhere and make sure written location is the dominant criteria. We have, in most of the TPA systems, there are parameters for eligibility, and they vary. You would be working with your TPA to come up with parameters that meet your risk tolerance. So, for example, how long between the patient encounter and the script fill date would you be willing to approve with respect to eligibility for 340B? Now, remember that up to a year is permissible if you can show that you've been responsible for the care of that patient and for that script for that full year, and that would be something that on audit, the auditor would look in your medical record for. Now, for example, on the written location, we did have a client that did not have written location as a factor, or even as not even as a factor, never mind primary. And this client had both a hospital and an FQHC on the same third-party administrator system, and they were two separate covered entities. Now, there was a problem with the patients because the patients would go to the hospital and then they would go to the FQHC and they would be treated as a continuum of care, but the third-party administrator would credit the wrong covered entity for the script. Now, in each of those cases, this is an eligible patient, eligible provider, eligible covered entity, but it was credited to the wrong covered entity, and these were each considered a diversion finding. And that just shows an example of how important that is. Other examples of diversion at contract pharmacies, this can arise when you've got prescriptions that are written at ineligible sites or they're not supported by the medical record. So if you have a physician who's writing scripts for friends, family, colleagues, and there's no medical record, this will be considered diversion. And the policies and procedures, you should have policies and procedures in place with respect to writing scripts for friends, family, or non-patients, and educate your staff. Any patient that's receiving care, including a script, should have an appropriate medical record and evaluation as well as follow-up, or it just shouldn't be permitted on premises at all. One of the things that we do need to look at is clinic-administered drugs. Now, in all cases, these must be traceable, including over-the-counter drugs that are administered on site. This can be very challenging because a lot of the trace mechanisms that our clients have in place include when an item is billed. If it's not separately billed, it's really hard to trace. However, we have had instances where auditors come in and they say that if you cannot trace a 340B package of Tylenol that you purchased, then and where it went to each and every patient, then they're going to find that this is a violation of the 340B program. So you must have that capability to trace it, and you must be able to trace it to each patient via the electronic medical record. Now, the next two slides relate to the definition of a patient. Most of this is what you know already, and just the highlight there is in the third bullet point where the individual has to receive a service that's consistent with the range of services for which the grant funding or federally qualified health center lookalike status has been provided. Essentially, for you, that means that the care has to be within the scope of the grant.
Right, but that's very important. For, you know, as we've spoken many times in the past for other things that we do for you, if you're providing a specialty service and it's not in your scope, it's not on your Form 5A, then you cannot get 340B for it as well. So in addition to all the other problems that could come up with regard to Form 5A, you got to make sure you have the service in order to be able to recapture the 340B dollars.
Right. Okay, so the only exception to the rule relating to that prescribing alone is not sufficient is for state-operated or funded AIDS drug assistance program, ADAP programs, and Ryan White. If a patient is registered, then the receipt of a prescription alone or drugs alone does make them eligible. What is the referral policy? As you know, most of the time we're looking at a physician or a prescriber who is either employed or under contract. The third requirement or has another arrangement. So that is referral policy. We know that capturing referral scripts at the contract pharmacy level is very challenging. We also know that auditors have approved scripts for this where you can show that there's responsibility for the care that's provided by the outside prescriber. Mind you, there are many software companies that have applications that support the referral process. What does this mean? You have to have you have to ensure that there's documentation both of the referral out for a consultation to a specialist or other person, and then you have to show that there was a report of a consultation that's been sent back to you and that is captured in the medical record. You also should be looking for documentation of ongoing co-management of this patient with the specialist or the outside provider. We advise our FQHCs to have a memorandum of understanding, if you can, with those providers with whom you have a frequent referral relationship. So the next big category, which comes up in the contract pharmacy setting, is duplicate discounts. Most of you know what duplicate discounts are. That's when when a manufacturer pays both a rebate and a discount on a drug that's used for either a Medicaid fee-for-service or a Medicaid managed care patient. In fee-for-service is pretty much always excluded from contract pharmacy arrangements, and in some states it's explicitly prohibited. And in 2017, HRSA required that all fee-for-service 340B claims be paid at actual acquisition cost. There had been some leeway prior to that, but today all fee-for-service 340B claims have to be paid at actual acquisition cost. And that's essentially impossible to handle through a contract pharmacy, because not only that, but because the contract pharmacy bills in their own Medicaid number, and it's really difficult to monitor that. If you have a special arrangement, you can get that approved by HRSA. Now, you have to make sure, what are the important things about the Medicaid exclusion file? The Medicaid exclusion file is the HRSA designated method for a Medicaid fee-for-service. If you want to include it, then you would carve it in. And then if you want to exclude it for Medicaid fee-for-service purposes, you carve it out. And that's something that you put on your 340B registration. We have seen a number of audit violations relating to incorrect designation of the carve-in or carve-out status.
Sorry, just to jump in for a second, I would mention this again if anyone who got on late. We will be sending out the slides and a recording in the next couple of days, so you don't have to worry about being able to keep track of all the slides.
Thank you. So you want to make sure that you've registered the correct Medicaid number or numbers that are used to bill Medicaid drugs and the associated NPIs. Billing Medicaid without the state-required NPIs can result in duplicate discounts. And note that the Medicaid exclusion file on the HRSA website, it's clearly been stated by HRSA, this relates solely to fee-for-service. It has nothing to do with Medicaid managed care, although we have had some manufacturers who have tried to assert that that's not exactly true. But we have HRSA now in policy statements and policy releases that has confirmed that. So in slide number 14, for Medicaid managed care, in 2010, the Affordable Care Act required that states collect the rebate on 340B drugs that are reimbursed by Medicaid managed care. So what's happening is, if you are not using the state-mandated method for identifying 340B claims, that states are increasingly taking the position that the remedy for that is that the covered entity has to pay back the manufacturer, just like you would if it was a fee-for-service issue and for duplicate discount in an in-house setting. But we've also found that most contract pharmacies cannot comply with the state Medicaid modifier requirements. And what we have found is that the larger chains will not do that. They will not make the attempt, and we'll get into this in a little bit more detail, but the smaller community pharmacies, mom and pop pharmacies, will take on this role, but the only way that they can do that is they have to be told which claims, but be told by the TPA which claims are eligible for 340B, then they go back and they reverse and rebill them, and with the appropriate modifier. Again, if your contract pharmacy does not include Medicaid managed care, then you've got to provide them with a list of these managed care plans to exclude. And the way you exclude them is by giving a list of the BIN, PCN, and group numbers to the contract pharmacy and telling them, okay, exclude from our 340B program any claims that are being reimbursed by these plans. This is very challenging because the managed care companies have multiple lines of business, and some are Medicaid, some are not. Also, they have to be vigilant. These Medicaid programs change these lists frequently. Just some, with respect to those situations where you are hoping to be able to capture Medicaid managed care, here's some examples of the state requirements. In New Jersey, as of 2017, New Jersey requires Medicaid managed care plans to identify each 340B claim. Mind you, the Affordable Care Act does apply this requirement to the plans, not necessarily to covered entities. So each managed care plan will have notified pharmacy providers on how to identify 340B claims. Mind you, it's going to come through to you in the long run if you're not making sure that your contract pharmacies are complying with this mandate. So you need to be able to monitor that. That's got to be part of your compliance program. So one of the things that we recommend is that in New Jersey, if you're filling Medicaid managed care scripts with 340B, you should carve in Medicaid on the 340B database, if at all possible. Now, some experts are claiming that if you're not billing in-house for Medicaid, that you don't need to carve in. We still advise you to do that if you can. If you have a problem with that, let us know, and we'll try to work through that. Mind you, that New Jersey historically had no 340B policy whatsoever. All claims were reimbursed at the regular Medicaid rate, whether they were 340B or not. Since 2017, this has changed, and now all fee-for-service has to be reimbursed at the actual acquisition cost. And this has resulted in a significant financial impact for health centers with in-house pharmacies that were filling fee-for-service claims.
Just so you know, Barbara's going through like 2 or 3 specific states now. We recognize that people are on the phone from many different states. It was impossible to put something in about all 50 states, so we just picked a sample of some of them. But if you're from a different state, which many of you are, and you have specific questions about your state, we're happy to answer those separately.
Absolutely. So, for example, in New York, Medicaid managed care requires that if you are going to carve in for either fee-for-service or managed care, that you have to do so for both. So that's a little different from New Jersey, which I think could be flexible. Fee-for-service claims cannot be filled with 340B drugs at the contract pharmacy level, and so obviously those are excluded. There is a requirement that each of the covered entities are required to make sure that the Medicaid managed care modifier appears at the claim level, identifier. And if they are being identified through reversals and resubmissions, which is really the only way we've seen this being able to be done at a contract pharmacy, that has to be done within 45 days of the end of the quarter. That's something that Medicaid requires. Now, we've been in situations where the contract pharmacy did not put on these modifiers, and the requirement is that the covered entity has to go back and provide these the rebates back to the affected manufacturers. In situations where this arises in the in-house pharmacy setting, New York Medicaid will go ahead and help you. They will trace those claims and let you know during a particular time period and particular claims how much of a rebate they received. Mind you, this is they're not able to do this at the contract pharmacy level because they're not able to trace through the Medicaid numbers that they have. So they can't help you for claims submitted by a contract pharmacy. Now, Connecticut does not have Medicaid managed care for its pharmacy programs, but what the impact of that, while it makes it easier, it does limit Connecticut health centers' revenues from 340B sales, because everything is going through fee-for-service, which means you have to be paid solely at actual acquisition cost, which is very different from other states where you can make some money on the Medicaid managed care claims. And there are other states that are also requiring state agencies to consolidate into, for example, a single purchasing unit, and in hopes that this will enhance their purchasing power. But if all of them or if all of their beneficiaries then are getting drug coverage through fee-for-service, this is going to have the same result and affect the revenues for those FQHCs in those states. What we think is a more workable solution would be a retrospective claims identification model at the Medicaid level. Mind you, we are not seeing that in many states. I think they are working on that in Oregon and in Pennsylvania. So hopefully something like that will come into play and make all of our lives simpler. On slide number 18, there has been a process now recently where the Medicaid managed care plans, Medicare Part D plans, also some TPAs are looking to impose lower reimbursement for 340B claims. In our view, this subverts the intent of the 340B program by shifting these savings to non-covered entities, and some states have actually passed legislation to prohibit this discriminatory contracting. For example, Montana, Oregon, South Carolina, South Dakota, and West Virginia. But for the most part, we are seeing that also PBMs. So some of this legislation doesn't include PBMs, and they've been able to do an end run around the legislation. So we should be writing to our legislatures and making some noise about this to try to get legislation prohibiting discriminatory contracting in each of your states. With respect to contract pharmacy compliance in general, on slide number 19, here's some of the common audit findings we expect to see, and we've already seen before. If you have, with respect to your contract pharmacy, a lack of oversight, this could be a removal sanction, meaning they're going to remove the contract pharmacy from 340B, and they don't permit you to utilize that contract pharmacy anymore. This could also affect the contract pharmacy's arrangements with other covered entities as well. There are other findings that find that there was no written contract at the time of registration. If there is an incorrect store or address or missing locations, sometimes it's the actual name of the pharmacy that doesn't exactly match up. And HRSA recommends that you have annual independent audits by an outside auditor who's experienced in auditing contract pharmacies. Mind you, this recommendation is something that we consider to be more of a requirement. So you need to be able to say that you are doing that, and you need to be able to produce documentation with respect to these annual audits. Having a strong third-party administrator is very critical in maintaining contract pharmacy compliance, but you're still responsible for getting those compliance programs in order. So more on the independent audit. It's, like I said, it's actually required, and they should be confirming that the pharmacy is following all of the 340B program requirements and be able to provide you with a report. One of the things that we recommend is that you engage your independent auditor through the attorney, through your attorney. This way, the findings will be protected under the attorney-client privilege. And one of the things we are finding is that a lot of the third-party administrators themselves are providing this service, but we question whether or not they are truly independent because they have a financial interest in the outcome. One of the things that we're going to be doing is we're going to be offering a mini audit to help keep our clients on track, and that's going to be something that we're going to be letting you know about in the near future. One of the important pieces of FQHC contract pharmacy compliance relates to sliding fee scale, and that's how much you're going to be charging for various services. Mind you that FQHCs are not required to provide a sliding fee scale for the actual drug cost, but they are required to provide a sliding fee scale for the dispensing fee. And what we are finding is that most of our clients are not actually implementing a strict sliding fee scale for contract pharmacies. We did have one instance where HRSA came in and did require that. So that's something that we need to look at a little bit more closely with respect to the sliding fee scale. Mostly what we're seeing is that for indigent patients, they are have a reduced dispensing fee, but nothing in the way of a 3 or 4 step sliding fee scale.
Right, but we have, like Barbara said, we have seen in the context of an OSD, HRSA coming in and looking for a sliding fee on your pharmacy dispensing fee. So if that does come up, reach out and we could help you deal with it.
Right. So slide 22, obviously contract pharmacy agreements have to be in writing. They have to meet the essential compliance elements in contract pharmacy guidelines, many of which have to be modernized, but we have ways of modifying the language to make them applicable. And slide number 23, one of the questions that arises, can your vendors, meaning your contract pharmacy or your TPA, can they order or purchase 340B drugs for you? They can't actually pay for them and purchase them, and they can't be responsible for doing that, but they can place the orders for you. That's the essential bottom line with respect to that. So the next complicated issue is the replenishment inventory system. Most contract pharmacy arrangements are using the replenishment model, which is a virtual inventory. And first they use their own inventory initially, an accumulator software then tallies up the eligible 340B patients and dispenses to those patients. And then the covered entity replenishes the inventory in an amount equal to the actual prior usage of the eligible patients. We'll be getting into a little bit more about replenishment later. There's some issues with that as well. In Medicaid managed care, once again, this can come up in the context of the contract with the contract pharmacy. So most of the time what we see in the standard contract pharmacy language is that they just say Medicaid claims are excluded or Medicaid claims are included, but you need to be very specific as to whether or not you're talking about fee-for-service or Medicaid managed care. So we have to be sure that when it comes to how these claims will be identified, who's going to be responsible for ensuring the claims show the required 340B identifiers when you're dealing with Medicaid managed care. Is that going to be the contract pharmacy or the 340B administrator? You need to make sure that this is clearly spelled out and the precise method for how that's going to be done as well. So, for example, with Medicaid managed care, a lot of the pharmacies that are including those, they are going to be reviewing the list of the eligible claims on a daily basis, for example, or at least every couple of days. Then they receive that from the third-party administrator. Then for all of the eligible claims that were reimbursed by a Medicaid managed care plan, they have to reverse and rebill them to include that modifier. And you need to state that process clearly in the contract. So right now, so far, HRSA does not audit for Medicaid managed care issues. They are only auditing for Medicaid fee-for-service issues. They are, however, lately we've been seeing on audits that they will point out problems to you as an area for improvement that you need to address in your corrective action plan. Okay, so other situations that come up, we have to be able to identify Medicaid managed care patients. So one of the problems is, how does your third-party administrator, how does your contract pharmacy identify them, and so that they can know who to put this modifier on for. One of the ways that's very helpful is there's a patient card system. You could give a database of all of these names to the contract pharmacy. That's probably not practical. You can help to identify these on the electronic script, and also physical inventory. If there's a physical inventory with specialty pharmacies, for example, then this becomes very important that you are able to identify Medicaid managed care patients and scripts prior to being filled. And one of the ways that we've seen them do this, for example, with a pharmacy, contract pharmacy that's actually on site for an FQHC, and that almost 99% of their patients come from the FQHC, is that they mark all the scripts as non-340B, then they reverse and rebuild the ones that fall out from that program. But if these are not carefully excluded later on, that could be considered a fraudulent claim. So this has to be carefully monitored once again. Slide number 27, contract pharmacies are also using Once again, the replenishment model, the accumulator software is used to tally it up, and the covered entity replenishes the inventory. With respect to your agreement, what are the issues that you want to see with respect to replenishment? You want to see that there's going to be an 11-digit match, and that they're on true-up. That true-up takes place when you have a drug that does not have enough dispenses to meet a full replenishment package number. So this truing up can occur when the pharmacy automatically replenishes the drug. And then if you don't get enough for that minimum package size, then you have to pay the pharmacy back for those drugs at their acquisition cost. So that's at non-340B. So you're not only that, but you're paying for usually you're paying for the pharmacy fees as well as the third-party administrative fees on all of those 11 dispenses, but you didn't get number 12, so you can't get a replenishment package. So what we recommend is that you have the longest possible time for replenishment, from 30 to 120 days. The longer the period for a true-up, the better. Other replenishment issues we've seen is the problems that arise with your pharmacies, is where the order size and the dose sizes don't match up, so they're not getting the right, where they say we've already given out 12 doses, but the order size that they get is not the right size, so we end up with a lot of confusion. Another problem with replenishment is something called inventory swell, where too many drugs are delivered to the pharmacy at once and they can't handle them. So most of your third-party administrators permit the contract pharmacy to have control over when they order the drugs. But you can run into a problem with that, where the contract pharmacies, they just decide, I'm not going to order. And so they can slow down the whole process. If they don't order, then they're not going to have the 340B drugs to fill, and they're just going to mess up the whole problem, the whole process for you. Other issues we're seeing is that there's with the formularies, and also if they have blocked drugs. Some contract pharmacies say we have the right to exclude and block certain drugs from your 340B program. Why would they do that? They're getting some kind of special rebates or special contracts for particular types of drugs, and they don't want to mess those up by having them be purchased by the covered entity instead of themselves. So also an issue is whether you're going to include generic drugs as well as brand drugs. Most of the time, the generics, there's not a lot of profit on those, and including them can once again mess up these generics contracts and rebates for the pharmacies. So we see most of our arrangements will exclude generics. Other replenishment issues we see is something called a negative accumulation or overpurchase. What happens is this might create a physical inventory, and that way the virtual inventory gets skewed. Ideally, what you want to do is make sure that you can separate the overpurchased 340B items so that they're not dispensed to non-340B patients. There's other ways we can take care of this. The FQHC could actually purchase them and take them in-house if that's a practical mechanism for curing this negative accumulation. There's also expired physical inventory, which may need to be destroyed. How did that happen? Whose fault is that? These are issues that we like to take care of in our contract if possible. And if drug does have to be expired or wasted, there are suggestions that this could be an error in accumulation and considered to be diversion, but we believe that if it's done properly and documented, that you can avoid any diversion findings. The next issue we have here is pharmacy compensation models. HRSA permits covered entities and contract pharmacies wide flexibility to come up with acceptable fee structures. Some common models are the flat fee per dispense, percentage of reimbursement, and reference price model. To get into a little bit of detail on this, obviously a flat fee per dispense is going to be your most compliant mechanism. Not sure that I have time to get into great detail on each of these. Flat fee per dispense is like, for example, that the pharmacy just gets $10 per dispense or $50 per dispense and sends back the full reimbursement back to the covered entity. And in a percentage of reimbursement, usually there may be a minimum dispense fee to the covered contract pharmacy, and then there's a percentage of reimbursement above that. The 15 to 20% I've seen pretty regularly, and maybe a $12 minimum dispense fee as the model. The next issue is the reference price, which we'll get into a little bit more. These situations, the reference price is where the pharmacy keeps most of the actual drug reimbursement from the third-party payer and remits back to the covered entity the drug price plus the difference between the 340B price and the non-340B price. And that has a lot of compliance issues. We'll get into that in a minute. 32, obviously, the flat fee per dispense is the best model from a compliance perspective. It's becoming less common. A percentage of reimbursement, this can raise issues with respect to total reimbursement, and sometimes, like I said, there's a minimum flat fee per claim. One thing that we're seeing, though, is they get a percentage of reimbursement. That means that the reimbursement is based on the pharmacy's contracted rate with each of the plans. They don't want to disclose these rates. Therefore, that percentage of reimbursement, they're not going to tell you which plan was involved in any particular script because they don't want the covered entity to know and be able to back out their contracted rates because these are strictly proprietary. What you end up with is a situation where you just have to accept what they tell you is true. The reference price model, this is something that where the pharmacy keeps all of the third-party reimbursement, the patient copays, and the dispensing fee, plus it gets a replenished drug. It pays back to the covered entity its own acquisition cost, meaning non-340B price or another formula like WAC minus blank %. What this does is it's kind of a troubling model because it really puts the benefit of 340B pricing is given to the pharmacies. The reason that this is used is to keep your pharmacies happy. And a lot of the Verity models, for example, and Rite Aid uses this model. And their concern is that otherwise they cannot make any money on these transactions. Winners only means this is preferred by our covered entities. What we're trying to do is make sure that each claim is only run through your program if it's going to be revenue positive to the covered entity. What this means is that if the 340B cost of the drug plus the contract pharmacy dispensing fee and the administrator's fee exceeds the third-party reimbursement for the drug plus any copays, then the drug is going to be considered non-eligible. If the total reimbursement exceeds all of these costs, then it's considered to be a winner. So we need to be looking for that if at all possible. Not all TPAs and contract pharmacies will agree to that, but that's our preferred mechanism. There's other contract pharmacy considerations. If you have indigent patients that are going to be getting a different contract pharmacy a dispensing fee, we need to be able to identify them. How are we going to identify them so that we can make sure that they get the lower price? There's a patient card system that we've seen before, database of all indigent patients. You can give the names to the contract pharmacy. You can identify them on the electronic script. So one of the other fees problems that we're seeing lately is that there are something called DIR fees and clawbacks, which is like a retrospective clawback by the plans against the pharmacy. So a pharmacy might get paid $100 for something in month A, but 3 months later they're going to be clawing back part of that profit. So what we are finding is the pharmacies are trying to pass along those fees to the covered entities, and the most important thing is it might be fair to do that, as long as we can say we're only paying for those fees that relate to our script, and we want to be able to see some documentation of that. Sometimes this is impossible, and I know that some of the larger chains, they're just not going to give you any documentation about that, and it's a take it or leave it situation. And but in our view, if these fees are imposed as a penalty for not meeting, for example, quality measures, these should not be passed on to the covered entity at all. Again, what other considerations do we look for in the contract pharmacy agreement? These are all your boilerplate stuff: confidentiality, HIPAA, the covered entity's right to examine the tracking system and to perform independent audits, and also insurance, indemnification, that there's no excluded or disqualified parties, and other important legal issues. Here's some of the contract pharmacies that we have been, the problems that we've been facing with contract pharmacies. It relates a lot to the payment mechanism. These arrangements include the contract pharmacy and the third-party administrative fees being deducted up front before any proceeds are sent to the FQHC. In the past, OPA has taken the position that this is not permitted, and we recommend that you don't do that, that you have all the money come to you and then you pay each of your vendors, meaning your contract pharmacy and TPA if possible. Mind you, we have not seen any audit findings on the upfront deductions yet, but what happens if the contract pharmacy refuses to pay the covered entity? There's two things you can do. One thing we've seen before is that if you can prevent this from happening, if you set up like an ACH transfer arrangement with the pharmacy, whereby any monies that are owed by the pharmacy or received by the pharmacy with respect to reimbursement are put into a special account. And that way the covered entity or the third-party administrator on behalf of the covered entity can withdraw from there the appropriate amounts and then pay back the pharmacy for these services. This helps to prevent some of these issues that we spoke about before, where they get an inventory problem, they've got replenishment issues, they get confused, they don't think they're getting enough of the drugs back, and things can end up being a situation where the pharmacy doesn't want to pay you back at all. So what happens in that situation is we've been writing some strongly worded lawyer's letters. Sometimes this is known to do the trick, and other times, non-payment can be very complex, and going through all of this data is just not worth it. And so you end up terminating and settling with the contract pharmacy. But that's something that we've been dealing with our clients, with respect to sending letters to the pharmacies. And so the consequences of non-compliance, as you know, there's administrative sanctions and removal from the 340B program, as well as civil monetary penalties and False Claims Act. Okay, so we only have like 1 minute left. So, we've talked about 340B as it relates to HRSA site visits, so we're not going to spend time now going over, we talked about it with regard to the OSV. Mm-hmm. I see there are a bunch of questions that have come in. We'll address those separately. I did want to mention we went through this all the way back to the beginning. I'm just going to run back up to the beginning for a second. For those of you, most of you on the phone, right, if you're outside of New York, New Jersey, Connecticut, or Pennsylvania, have never met you in person, subject to the coronavirus canceling the NAC conference. I will be at the NAC conference the week after next. And so if you want to, I don't know why there's a whole bunch of typos on this slide, but if you want to meet with me in person, I will be there, and you could reach out in advance by email or by phone, schedule some time to meet with me. And I look forward to speaking with you. Thank you, everyone, for joining us today. The slides will be coming out in the next couple of days. We will respond to all of your questions. Thank you very much.